Okay. Hello, everyone. Thank you for your kindly invitation for this sections. I will talk about unilateral biportal endoscopic surgery. As you know, this technique is a minimal invasive technique, and this technique is a medium, fluid medium technique, like uh, you know, hip arthroscopy or knee arthroscopy or shoulder arthroscopy. But the difference in this surgical procedure, the problem is that the working space. In the other surgical arthroscopic procedures, you have already a working space, but in this procedure, the first thing is creating a good working space with a good hemostas. About this is a Dr. Son from Korea. I worked with him. He talked about sans space with multifidus approach. You can create an approach here under the multifidus without no damage of hemorrhage. The this most important thing is this surgical procedure. This work fluid basınç ne diyordum? Sorry. Yeah, fluid pressure, because there if input is here, output is here. If you close here, there's an increase of the pressure here. This is important. If you diminish the pressure, it will be hemorrhage. Okay, optimal water pressure is 30 and 50 millimeter and mercury in this procedure. We don't use any pump. We use just gravity. If you put the fluid bags from the table with 50 or 70 centimeter degree, you can get this pressure. If you cannot get good pressure, insufficient working space, bleeding, and limited visibility, it will be not good. And you can account with neurological injury and throat damage. If you have a high water pressure, this is the important muscle edema, and this is the most important thing is interspinal bleeding and interspinal pressure increasing. This is important. This is a good work. In 5 phases, they evaluate the intracranial pressure, and first 3 phases is about before the laminectomy, and the other ones outflow is open and closed. As you see, after the laminectomy, its pressure is enhancing like this in maximum at here. If you outflow is open, you can get a good water pressure. If you close it, water pressure will be high, and this will not be good for intracranial pressure. This is our surgery, and there's a scopy and and a monitor, and we use all of the procedure neuromonitoring, and this is my assistant to look here to help every stage of the surgery. Anesthesia here, the surgeon is here, scopy, and monitor is here, scalp nurse here, like that. I will present a case, and I will talk about this. This is a 34 years old male. He operates before 6 months with disc herniation, but he comes us with next of herniation and left left leg pain. You can see the disc herniation, and you can see the laminectomy defect. Please. After you find the portals, you should find anatomical landmarks, and we will use ablation and coagulation to create a working space here. This is caudal, this is cranial, this is spinous processes, this is lamina. Okay, the most important landmark is spinolaminar junction. We try to find here. This is lamina, and here is we can go. This is here a facet. As I said, the first and most important landmark is spinolaminar junction is here. It's like that. When you see that, you can begin to decompression of bone. Yes, we can go. Now, after to find the spinolaminar junction, we'll decompress all of the soft tissue. Because of this is a revision case, all of the phloem resected, but in this procedure, we will resect the phloem at the end of the osseous decompression. We use burr to bone decompression. This is up, this is back, and this is lamina, and spinolaminar junction is here. Yeah. We want to reach to another landmark. The second important landmark is, we can go. The second most important landmark is that, as you know, ligamentum flaum shapes EU, right? That it comes here like as a butterfly. You should see here. If you see here, it means that you are the middle of the canal. After this, you see this landmark. You can go the other side, and this is mid sagittal area, and we can go. And then we're going with ablation and coagulation. You should not use continuously ablation and coagulation, because in the surgical area, temperature will be high. This is a good study in an ankle joint cadaveric history. Most of arthroscopic procedures, the surgical site temperature between 30 and 90 centimeter degrees. Okay. And this is another good work. If you get 42 degree in the surgical area, any anatomical change or any markedly change will not be good. But if the temperature will be 80 degrees, lesions cause significant nerve injury, and Wallerian degeneration will be seen, and then you cannot see the nerve helpless. This is a good photograph, and above the bone, you can use RF with ablation. It's 7 and coagulation 2. In epidural space, ablation is 3 and coagulation 1. And near the dromator and the other nerve anatomical structures, don't use any ablation, just in one coagulation. Yes. We are now we are going on. Yes. Yes. And then after using the other side, we're getting more bone to decompress the radicular nerve. This is the radicular nerve. Okay, we can go. Yeah, please. And then we dissect the root to find herniation is here. Yes, we find the disc. This is root. Other complication, this important thing is, the most important thing is about the complication, insufficient working space. This is the most important. And because of that, failure to achieve hemostasis and early phase of learning curve is important. In this work, you can see a cutoff sign is 54 cases is just enough for is, yes, I am good for that. In this period, you can go more complications. Most complications is dural tear, hematome, and incomplete decompression, and the other ones, disc recurrence, instability, and the other neurologic complications. All of them, this is a good meta-analysis. You can see here, if we just use water, you can see there is no more infection here. This is about this procedure is good about infection. This is a case to operate here. Is a 81 years old female. You can see a sagittal balance, and she has radicular pain and back pain. You cannot operate with the open surgery. This is the MRI sections, and you can see L4 and 5, L5 and S1 nerving of canal and foraminal stenosis. This is perioperative scopy signs. This is endoscopic working tool, and this is the sector. This procedure names is ULBD, unilateral laminectomy and bilateral decompression. This is we study we make operation from the left side from here, and you can go to the other side with undercutting. The other foramen is here. This is actual CT of the patient. You can see that. You will work here, and you can decompress all of the canal with this procedure. This is photographs of the perioperative waves. You can see the other one, the other opposite radicular nerve is here. And you can see three small incision and the big satisfaction for this patient. The other one is 56 patient with lumbar spinal stenosis, but in this patient you can see this one, and you can see the narrowing and vacuum phenomenon on this here and facet dislocations. Sorry, in this patient, patient have instability. The instability is a contra is not useful for this procedure, but the patient want this procedure, and we make this from the left ULBD procedure for this patient, and this is the left, the other side opposite nerve and left nerve. You can see two-level decompression with three lumbar. Thank you. Thanks so much.